Hello, and welcome to another episode of Boundless Body Radio. I'm your host, Casey Ruff, and today we have another amazing guest to introduce to you now. Katherine Tague is a licensed therapist specializing in teens and young adults struggling with stress, anxiety, and related conditions such as OCD and eating disorders. Katherine completed her clinical internship at Clementine Brewercliff Manor, an eating disorder treatment center for adolescents in Westchester County, New York. After completing her master's in mental health counseling, Katherine joined Backcountry Wellness, an eating disorder treatment program in Greenwich, Connecticut. While at Backcountry, Katherine served as a primary therapist and then the program director of the residential treatment program. Katherine has additional training in metabolic therapies and is passionate about approaching mental health from a whole body perspective. Katherine's work focuses not only on addressing unproductive thought patterns and behaviors, but also lifestyle changes that can help improve brain health. Her other credentials include Ketogenic Diet from Mental Health Clinician Training through Georgia Ede, MD, and a certification in Metabolic Psychiatry for Non-Prescribers through Nicole Laurent, both of whom have been some of our absolute favorite guests on our show. You can find Katherine at her current practice at Well Supported Behavioral Health at www.wellsupportedbehavioral.com. Katherine Tague, what an absolute honor it is to welcome you to Boundless Body Radio.
Casey, thanks so much for having me.
It's such an honor to host you. I was so confused when I heard you on Low Carb MD. I loved the episode that you guys did with Brian and Tro. I reached out to you immediately that day. Like I wanted to host you, and it was like an hour later, I got an email from Nicole Laurent. It was like, "Oh, you should definitely reach out to Katherine." And so it was just like super confusing thing where I had two emails out there with your name on it. And I'm like, but did I reach out? I think is it the same person? Like, what's going on? It really confused me.
And then I had a task of, I was driving to work that morning and I had seen the LinkedIn notification come through and I couldn't find your message. I sometimes, I had to learn, like, I don't know as much about LinkedIn as I think I do. I kept saying to Michael, I'm like, I swear there's a message in here from a guy I want to respond to. So it was good. It was good. There were two channels.
That's so funny. Yeah, it was weird learning in the last few years that you can use LinkedIn for other things than like just posting your resume, which I thought it was for. It's like this whole social thing and a great way to reach out to some people. But yeah, I don't use LinkedIn very often either. So I'm glad you found
it. Right.
That's awesome. Well, like I mentioned in the introduction, Nicole Laurent introduced the two of us. Got to meet her in person finally after hosting her 4 or 5 times on our show, and also got to meet Dr. Georgia Ede at the San Diego Symposium for Metabolic Health. What an honor to meet both of those people in person. And just like everybody else that I've ever met in this space, they are just as amazing and kind and gracious in person as they present themselves online. They're amazing. I love both of them.
Oh my gosh, like give me an opportunity to just say how grateful I am for Nicole Laurent. Like she, and Georgia too, like so gracious in the little bit I've been able to engage with her. But Nicole, like, I think I must have cold emailed her. She was tweeting about like, if you are a mental health practitioner, like you have an ethical responsibility to be interested in this stuff. And I just cold emailed her and said, like, I need guidance. And gosh, she just like, some of the biggest gift Nicole has done for me is like inspire confidence in me and be gracious to me and take the time to teach me. Like she's just so I think that the space is so lucky to have her, but certainly personally I'm very lucky to have her.
Yeah, she's amazing. One of my favorite things on the show is to get her a little bit wound up about some of this stuff and like talk about like informed consent and like when she gets going on telling people that they need to let their patients know that this is an option, she gets so wound up and passionate. I absolutely love that. So what an honor I'm sure it was for you to be able to work with her and learn under her, and also Dr. Georgia Ede, who both, again, just absolutely amazing people.
And just to orient people a little bit, like metabolic health aside, Nicole would be in my field, for my license, for my profession, a very experienced clinician, a very senior clinician. She's someone who, even conventionally, I would want supervision from, metabolic health aside. And then the amazing benefit for me is that on top of that, then she really is like, I just feel one of the first therapists who is really doing this stuff. So already alone, she would be an amazing resource for me. But yeah, the metabolic psychiatry stuff on top of it she's amazing.
Yeah, it's so cool. I love that this field is emerging. Metabolic psychiatry is just such a wonderful field, and we're getting so many more case studies just piling up. And your work specifically with things like eating disorder. In my field, nutrition coaching, personal training, I've argued many times that there's probably not many of us that have done this for a long time that don't think about this constantly, obsess about this constantly. I'm constantly like 24/7 learning about nutrition, trying to think about things in a different way. And then I find myself obsessing about food. And I wonder, like, do I have orthorexia? Do I have issues eating around food? I mean, we just went through Thanksgiving, and my clients are asking me, like, what things are you going to give into as far as like treats and desserts? And I want to say, like, yeah, I'm going to indulge in a piece of pumpkin pie, but like when I start eating pie, I don't stop until I finish an entire pie. And so for me, I have to abstain with certain things, and I have to be more on the carnivore side. And then I wonder, like, what the hell is my problem? Why can't I like give into some of these things? And so it's so interesting to kind of differentiate the difference between anorexia, orthorexia, and all these other eating disorders that you deal with all the time. It's quite difficult.
Yeah. Yeah. I feel like what I felt for a long time is that the stuff that I see clinically, or the stuff that I just see as a person, like same as you, like talking to my friends, talking to my siblings, the stuff we see in our experience of food, it's just like not super well represented by the diagnostic categories. For the first thing is that I really believe, and this is not shared by my colleagues, I am a renegade in the eating disorder space. I am probably controversial in the eating disorder space, that I believe that a ketogenic diet or even a carnivore diet is an amazing therapeutic tool for people. Really, it's just like I'm a mental health practitioner. From a brain health perspective, it's an amazing, amazing tool you can leverage. Now, it also happens to necessitate that you cut a lot of things out. I've been noodling with this idea of like, what do you eat and how do you come to that decision? I've been working on making this framework for myself and for my clients. I call it radical body respect because I think that if it's about respect of body, but I think not just like the physical entity, but also body as container for the soul, container for the spirit, and then how can you be most respectful to yourself within that paradigm? So if pumpkin pie is most respectful for yourself on that day, it really might be like you can absolutely convince me that pumpkin pie is the most respectful thing for you. However, Casey, it sounds like if you're someone like you, where pumpkin pie is going to send you on a journey for a series of days, like maybe that's not the respectful thing for you. But I think what frustrates my clients, and I get it, is in most of my I'll meet with clients and they'll say like, it's this cake. I have this cake at home and I want the cake. And if I start on the cake, then I'm eating cake and I'm eating a whole cake and I'm eating it for the better part of 48 hours, I'm eating a whole cake. And in my field, the conventional training is you're supposed to have cake, no cake, hold cake, eat cake. You're supposed to like repeatedly expose yourself to cake as if you had a phobia of spiders, as if you had a phobia of elevators, right? Of bridges, of any of these things, phobia of flying, you get on planes. So expose yourself to the cake. But I think that only exposing yourself to cake is to ignore a little bit of what we know about addiction science now, about neuroscience, and about the way high fat, high sugar foods implicate some of those addictions pathways. And I don't want to be a clinician who is ignorant towards those fields. I don't want to ignore that science. That science is relevant to me and my clients. So usually I go into sessions and I say, well, you have two options. We can repeatedly expose you to cake and you can get to know cake and moderate cake in moderation, or we can say cake is not my food right now.
Yeah. Very well explained. I love that. Yeah, I absolutely love that. It's also very near and dear to my heart because my wife struggled with anorexia when she was an adolescent, and she was in an outpatient kind of program at age 14. And I personally have seen her on a ketogenic kind of slash carnivore diet, step away from things like conditions like Raynaud's she doesn't have anymore, and like she was on Adderall, she's not on Adderall anymore, and her mental health is so much better, and I've seen so many improvements. But yet like it's a little bit awkward when we're with family and they look at this as like, wow, this is such a restricted diet. Why are you putting somebody who's restricted their whole life on a restricted diet? And it's like, first of all, I'm not putting anybody on anything. It's what she wants to do. But it's hard to kind of explain to people because again, the conventional wisdom, of course, like justifiably, is you should not restrict somebody who's been restricting their food all the time. But it's a totally different paradigm. And we're seeing all the case studies now to people that are really truly improving by eating this type of way.
It will be so interesting. Right now at UCSD, Guido Frank's lab is doing ketogenic diet for adults in PHP with anorexia. I can't wait to see what comes out of that. But you know, it's interesting. Like I experience carbohydrate restriction. Like I get it. Like it's restriction. You're cutting out foods. I totally get it. But what's been fascinating is like the profile I find in my work, especially if you are clinical levels of anorexia or bulimia, is you are fat phobic, dietary fat phobic. So, you know, there are people who would say like, what a restrictive diet. Well, do you know how big of a deal it would be to get someone with anorexia, with bulimia to have a steak? I sit professionally and I do steak exposure with my, and these are not people
I
who are
love
on any
that.
diet, right? These are just like kids and teens who like want to reintroduce red meat because meat aversion is a real thing. And it's fascinating how like, I don't think people understand, like, if you are clinical levels of eating disorder, it's a very, very big deal for you to eat steak and eggs. I mean, it major.
Yeah, that's a really good point. Katherine, I wonder if you could tell our audience how you got into this, because this wasn't originally your professional track. If I understand your story correctly, you're doing something completely different and then got into this later. How did you get interested in this stuff?
Well, I'm so impressed with you because my first job out of undergrad was I was a podcast producer. I worked on a podcast team. That's how I met Tro. And it was 2020. As you imagine, it wasn't a great time to be in news. I was like in really
Not
conventional
the
news.
best.
And I was just like, I don't even think a job change will fix this. I think I just got to go work with people. So basically on a whim, I went and I did my master's and it turned out to be a really good thing for me. I've loved it. But it wasn't so long. I wasn't so far into my master's before I was sort of, I was actually struggling with a little bit of anxiousness and probably what I now know as like obsessive thinking that I'd never experienced before. It was foreign to me. I'd been a dancer in my life, so I probably had food and body weirdness, and I was able to just reintroduce all foods and come to a lot more place of body acceptance. But my diet was like non-specific, like 22-year-old girl diet, like eating just whatever, whenever. And I was really anxious in a way I couldn't explain. And I started to eat more of a dietary pattern like my mom has always eaten. My mom has basically been low carb, keto, or carnivore, somewhere on that spectrum since I was early in high school. And I found that it helped my anxiety so much. And my mom said at the same time, I was in my clinicals and I was really disappointed with clinical outcomes. I felt like kids were really sick and people were really struggling psychiatrically. I didn't feel like we had that good of outcomes with our medications. And my mom said, well, and I just started being more and more drawn towards thinking more holistically about mental health and just thinking more about mechanisms, which definitely comes from my mom. That was all her. And she said, if you're interested in this stuff, I'd like you to look at a Georgia Ede, and just gave me the background and the primer. And this was before Brain Energy or any of that had come out. I did the course with Georgia, and I think Brain Energy had come out the following fall, maybe. And so I felt like I was becoming interested in this and coming out of grad school at the same time as this whole metabolic psychiatry space was erupting. And yeah, so I feel like I've always had a foot in two worlds. On the one hand, I've always done pretty conventional mental health treatment, eating disorder treatment at the residential level. And then on the other hand, I have this metabolic health interest. And I think the two are, they're not separate. They're close. They're relevant for each other, even though we don't often see them combined in the real world.
Wow, that's amazing. So cool that your mom was into this stuff and got you into this stuff as well. In the beginning, like learning about metabolic psychiatry, you mentioned being disappointed with the clinical outcomes and conventional training. I mean, did it take you a long time to kind of think that eat something like eating or lifestyle could actually help mental health as well?
I think that everything happens for a reason. So like I'm hugely grateful in retrospect that I was so anxious at the beginning of my master's, because I think that if I hadn't had that experience for myself, if I didn't know what it was to like have your brain not feel like it's your own, I probably wouldn't be so passionate about this stuff. I would probably be like other therapists who are like, you're just not doing the CBT well enough, you know? Like, but I knew myself and I knew this wasn't how I'm supposed to feel. Um, I'm sorry. Will you ask the question again? What am I supposed to be answering?
Just your own. Oh, you're great. It's just like your own experience with this kind of stuff, and like realizing that metabolic psychiatry could also help with what you had learned being like clinically trained.
Yeah, like there's just limits. Like, I think part of it is that everything is magnified for me. So the kids, I've always done eating disorders, and the kids I meet, and I basically have always done, right now my population is between 11 to 21 when I'm in the res, which is the really clinical setting. So I call them kids. But the kids I meet, they usually have undernourished brains. They've been not eating properly, or they've been purging, vomiting for some time. So their brain is not functioning optimally. So probably everything was like overly magnified for me. But I was like, these interventions they're teaching us, they just don't work well enough. Nicole talks about this. Like the top line cognitive intervention, I was talking with my mom about this yesterday, is like, really, to me, the gold standard now is basically mindfulness. You'll see this in DBT, you'll see this in CBT, all these frontline treatments, even ERP for sure. To some extent, it's really all about mindfulness. But to engage in mindfulness, like metacognition, right? Thinking about thoughts. That takes a really healthy person. Like you got to have a really healthy brain to do this stuff. It takes a lot of hard work. And I felt like, oh my gosh, like we don't have healthy brains to begin with. So how can we ask people to do this psychotherapy? It's not going to fix what's wrong for them. And then on top of it, just the data on our medications as they exist, it really leaves something to be desired. The other thing I have seen throughout my career a lot is parents are slow to put their children on medications, and probably rightfully so. And all I mean by that is that I work with some really young kids. So what does it mean to go on a medication when you're early in life? There's just implications to that, even just behaviorally, right? What does the child learn about themselves from needing to take something every day? And so that was the other thing I was seeing. People are slow to do medication intervention. I'm not sure the outcomes from medication intervention are as optimal as we would like them to be. If they were, we probably wouldn't see increasing rates of mental illness in this country. And then our brains and bodies are just not healthy enough to do the really optimal therapy work.
Wow, that's super well said. I've never thought about it exactly in that way. And I've had Nicole reiterate this many times. Like we look at all of these things as like tools in the tool belt, things you can do, that the techniques you learn. But you're saying that like without the brain being healthy, those techniques are not going to work. It just seems like all of that stuff would be so much more effective and usable if you started with the nutrition piece to get the brain in a much more healthy state. Have you found that to be the case in your experience?
Definitely. Like what there are things about the eating disorder world that I love. And one of the things I work with a lot of in the conventional eating disorder world, I work with um, a nurse friend of mine. She says to parents all the time, like, parents will come in and say, should we try this multivitamin, or should we do this supplement? And she will say, we would prefer your child get what they need from their food. And like I do love that about eating disorder treatment. You'll hear in some eating disorder professionals say the food is the medicine, right? But And I believe that. And that's a beautiful thing that like in my work, we spend a lot of time on refeeding, but if the food is going to be the medicine, then this is my major thing with my space is like, it's gotta be good quality food. It's really gotta be good quality food. Um, because, because the brain is in a fragile place and we want what we're taking in to be optimal. We don't want it to be more inflammatory.
Yeah. Yeah, very well said. Before we talk about what those foods can be, I do want to just comment on your own personal story with the anxiety that you experienced. What did you notice about changing your diet related to your own personal health?
You know, I don't think I ever had that like meat aversion, dietary fat. I think I was always like pretty good with meat of all kinds. I think it just was about me being a little bit more specific about what I was taking in. Um, but I just noticed calm, like just once I could make some ketones, I just was able to be a lot more calm and a lot more resilient. What I have been pretty passionate about is um, also, I don't have any data on this, but I feel like once I was in a place where I was really specific for a period of time and I really watched what I was eating from a brain health perspective, now I feel like I'm pretty resilient. Now I feel like I could go on vacation or do whatever and come out of it for a couple days and do things that are probably not optimal. And I'm pretty resilient. I just don't struggle in the way I used to. Um, and if I find I am having some more anxiousness, um, then I just try to dial it back in and make some ketones again.
Yeah, that's amazing. That's the primary reason why I've stuck with my own diet as well. Is like I didn't realize how anxious I was until it went away. We've talked about this before. Is like you don't see the fog when you're in the fog, but when the fog lifts, you realize like, oh yeah, wow, I was experiencing that. And when stressful things would happen, I'd spin around in all these kind of scenarios that were never going to happen. Where now I can kind of handle that a lot better. So it's cool that you've had that same kind of experience. You mentioned some of these things getting worse in adolescence. I think most people would understand that, but just like state of the state, like where are we now as far as mental health? Is it truly getting worse to the extent that I seem to kind of observe in that population?
I actually don't have really good recent data on this. I know they did large population studies following the pandemic, and you can see it. There's total increase. It's possible it's just more awareness, but I don't think so. I really think kids are struggling and it will be hard for me to say like this is the reason why. Um, yeah, I know following the pandemic, there were large population studies that will show the increases. Um, but and it's always possible that we're more aware, but I think earnestly people are struggling.
Yeah,
Yeah.
it sure seems like it for sure.
Yeah.
How about the diagnoses of some of these things? Like, how difficult is it to diagnose something like anorexia or OCD or binge eating? Like we throw those terms around, and you mentioned brain energy. Chris Palmer does such a great job in his book talking about how difficult it is to diagnose things based
Yeah.
on the DSM-5, and like how difficult is it to diagnose something like anorexia?
I sometimes see good things that are consistent between the metabolic psychiatry world and the conventional therapeutic mental health world. One of the things that's consistent between what Chris writes about and what I got from my professors is when I was in graduate school, we did not put a premium on diagnostic categories in DSM-5. I took one semester-long course in diagnosis, but I'm a counselor ultimately. So there wasn't a premium. Yes, I have diagnostic privilege in lots of states, um, and which means I can diagnose if I should. But my professors didn't put a premium on it. It didn't feel like a super important thing to them. I think because similar to Chris, it's like, well, we all just kind of got this neurobiological soup and knowing that you are prone to obsessive thought patterns, intrusive thoughts may help me modulate the kind of therapy I'm going to do with you, right? We're going to do some more exposures. We're going to do that kind of thing. Or if you've experienced something traumatic, we're going to do a different kind of thing in the therapy room. But beyond that, like, I think what we have to ask ourselves is like, how does the diagnosis benefit the person? And does it benefit them? I don't put a premium really on diagnoses. Now, how hard is it to get a diagnosis? Depends on it definitely depends on what the person's experiencing, right? Like, but you know, if your child is afraid of most foods, has dropped some weight, and it doesn't, and they don't have to be underweight really to get an eating disorder diagnosis. I should talk about that a little bit. But if they're afraid of foods, they've dropped some weight, or if they haven't, if they have compulsive exercise patterns, if you tell them you can't go on your run today and they are crying and crying, you know, it's mostly about daily functioning. If it's impeding your ability to function as you would like to, it's pretty easy to get an eating disorder diagnosis.
That's interesting. That sounds very progressive as far as your education and
Yeah.
not really obsessing about the DSM-5 and making specific diagnoses. Is that, like, from what you've observed in your field, is that normal, or was your school kind of more on the progressive side?
It's possible my school is more on the progressive side, but I would say about master's level clinicians. So that's social workers, marriage and family therapists, and mental health counselors like Nicole and I. It's so person-centered. Like I have a friend who's an MD, and he calls me secular secular rabbi. I don't know, right? Lay rabbi, right? He has like a joke about it, which is basically like, in our modern world, like, you know, people don't go to their pastors, or people don't go to their rabbis in the way they used to. What they dedicate time to is doing some therapy, right? Having a safe space, having a safe container. So I find most of these master's level therapist programs, they just put a real emphasis on like, you are serving someone, be of service. And they make it really person-centered, and really, like, there is justice in that too. Like, it's so much about empowering the person and not stigmatizing. So I think kind of across the board, that's the training now. Like, it's just most important that people are feeling better. It's not most important that people are feeling like. That's something I love about a lot of master's level programs. I feel like it's not and you'll learn this is actually in the curriculum. It's not a sickness paradigm. It's a wellness paradigm. You know,
That
like
that stuns me.
yeah, yeah.
That's great.
That was my experience. And I feel like I see that in my colleagues. Yeah, but there's certainly an emphasis on justice. And so I think that's probably why, like, it just feels like it's more respectful to people's autonomy
Wow.
to work in more of that paradigm.
That totally stuns me. I was not expecting that. That's great. Really cool to hear. Let's throw out metabolic psychiatry. Pretend you never had heard about that before. Conventional training, again, you mentioned you were a little bit disappointed by it. What would be the typical kind of treatment path for somebody with anorexia? Just say, use my wife as an example, 14 years
Yeah.
old. Obviously, eating is throwing off her life, and she would be the one that if she didn't go running in the summer, she'd be super upset. Like,
Yeah.
what would be the conventional treatment pattern? How would you work with that, and what would be like a pretty good outcome just using those tools?
In my experience, it usually gets identified by parents or by pediatricians. Um, Parents, if they're watching their kids, you know, most parents are aware of this stuff. They're like, that's a little weird. She used to be able to eat most things. Now she's only, you know, we sit at the table at night and she only wants the salad, or she's only eating fruit. And she's upset when I tell her we got to go to grandmom's. You can't do your workout today. Like, parents are probably noticing that kind of thing. Pediatricians can be really good. Most pediatricians are adept at just saying like, yeah, I think this is, you know, this is where she should be on her growth chart. So from there, you would get identified. If it's really at an acute state, if the child cannot take in food at all, they may go to hospital for restoration. And once they're at the hospital, if they really can't bring themselves to eat hospital food, at that point, and the weight were really compromised, or the heart rate were compromised, or one of these EKG, one of these other biomarkers, at that point, they would look at doing feeding tube. So that's hospital level care, and that's the top level. I should say that if your pediatrician catches it, a first-line treatment is family-based treatment where parents refeed their child in the home. And basically parents get really focused on saying, like, we are going to help you put this weight back on, and we're doing this as a family. And they create a lot of boundaries and a lot of structure for their child in the home so that it doesn't have to go to that next level.
Gotcha.
There's tons of nuance here with all this, pros and cons, right? All the things, all the disclaimers. So, but perhaps if your child's really struggling and their biomarkers are really at concerning levels, top level is hospital, then you would usually go into a residential treatment program. After that, there's PHP program, which is like day program, and then IOP, which I usually call afternoon program, but it kind of can be anything. So those are the levels of care. And after the hospital's like acute, like you're really not doing therapy. You're really just refeeding the body. And then after that, usually you go to a residential program, typically because what we found with that individual is for whatever reason, they can't eat at home. It's just not enough. Being at home with mom and dad, at home with your spouse, it's not enough support. You have to be, there's utility in the res, actually. Like I always say this, like if you're really struggling with a substance, there's utility in rehab, go get sober. It's sort of like that. Like you have to convey to the child often, like, it's too serious. You can't go on this way in your real life. You have to go away. So there is some utility in going to residential treatment.
I see. Gotcha. And when you say that you were disappointed with most outcomes, how many kids get fixed? I mean, we know the data behind, anorexia and unfortunately the number of suicides and poor outcomes. Like, again, with more conventional care, what were the outcomes like? Like, what would you expect?
Well, one of the things is, like most things, there's just like tons of variability in eating disorder treatment. But, I'm sorry, there's a vacuum running. Can you hear it?
No, can't hear it.
Okay. There's tons of variability in treatment programs, but one of the things that's been just relapse rates, I should say this. Relapse rates in eating disorder treatment are not good. They're high. If you look at them, they're high and they're rising. And so eating disorders overall just don't have great outcomes. One of the biggest things that I feel like leaves something to be desired in these treatment programs, and there's a lot of awesome in these treatment programs, but like you'll hear Michelle Hearn talk about this. One of the biggest concerns for me is like when a child's in the hospital and they're getting that feeding tube, it is nowhere near optimal nutrition. And if you think about how compromised their brain is, and then the food they're getting through the tube is not optimal. When they get off the tube, then it's hospital food, still not optimal, and they're not getting therapy. So parents are like, she's still really upset every day. She's still really low mood. Once they come in and they're at a res level of care, the food quality is better. But what you will see is that they put a premium on exposing people to fear foods. So that looks like a packaged Uncrustable, a bag of Doritos, a pudding cup, like all these things, an Oreo cookie, all these things that are supposed to be like, you can't be afraid of these foods. And I don't think you should. I think it's pathology to be afraid of an Oreo cookie. I think there's no reason. But is that an optimal food for your brain? Probably not. And it's a lot of what you will eat when you're at a residential level of care, which is to me one of the biggest stumbling blocks in the field right now.
Interesting. Okay, so speaking of metabolic psychiatry, mixing that back in, you're talking about what are the healthiest foods. Tell us what those foods are. And is it simply an elimination of a bunch of the stuff that you mentioned, like the Doritos and Oreos, which now we can't have as show sponsors? Thanks a lot. Or is it about adding in some of the other healthy foods, and what are those healthy foods?
For most of the families I work with, like I spend a lot of time just being like, what are you having? And they're like some egg whites, some waffles. And I'm like, what about some yolks? Like for a lot of the families I work with, I would just like to see more animal foods just because I think it's the most nutrient dense and bioavailable food for the brain. Like, so I think there are some families where like you could just introduce some stuff, some more beef, some more lamb, some more eggs, some more yogurt, like whatever, and that might be enough. Now, I really believe that. And there are some kids who do beautifully just as it is, right? I'm not saying it's everybody. Some kids do beautifully on conventional treatment approaches. But if you're someone who up until now you're still really struggling with those intrusive thoughts. You're still really struggling with the psychiatric nature of this disorder. Some of what these case series are showing us is that when you really get specific and you try to make some ketones, it's considered most safe when you're at a weight restored place. So, right. So when you're in a weight restored place, because, and the reason I would say that that's still a good way to go, be in a weight restored place before you, try to change your diet up too much, is I would be concerned about the dietary fat fear. So if you're someone who you're not weight restored and you're kind of afraid of fat, well, like I don't think you're really going to be able to get back to a healthy place for your heart on a chicken breast. It's not enough food. You're not going to get back to where you need to be from a medical stability perspective on lean meats. It's just not going to happen. It's not going to be, and it's not going to be optimal. So anyway, that's what I think. I think for most people, introducing more animal foods would be enough. But if you're still having real psychiatric challenges, I think at that point it's time to think about, like, can I create some ketones? Should I be more on a therapeutic ketogenic diet? Or should I just try to remove some of these more inflammatory things and see how that goes, even as a first step?
Interesting. Yeah, that's really well said. I hadn't considered that as well. We'll talk about the parents in a minute. I'm super curious about that. But as far as the kids go, compliance, right? Like, how compliant are these kids to, once they are weight stable, like you said, to trying to add some of these foods in? Is it terribly difficult? These kids have to go to school and they've got, sports where assumedly they're getting fruit snacks and orange juice because nobody's ever been able to play a soccer game without having snacks every 15 minutes. Like, how are the kids complying with this kind of thing?
Are we talking about kids who are on a therapeutic diet or kids who are on they're just weight restoring?
Once they're weight restored and they're trying not to have that recurrence that you're talking about, that so many kids are experiencing, and you're introducing the concept of, like, let's get you some really nutrient dense foods. How challenging is it for the kids to adopt this type of diet in general?
I mean, I find, like, with a lot of my eating disorder kids, so like they're in a pretty good place, they're weight restored and they're out in their life. I just find that they are still like, I find the fat phobia, the dietary fat phobia. They're not drawn to those foods. They are drawn to pretzels. Like, they don't really want cheese. So that's like still a stumbling block for me. Like, even my kids who are in a really pretty good weight place, I'll be like, we're getting some meat in, and just because I think it's that important. I actually haven't done a lot of work with having a kid I haven't personally had a client who is doing a child doing a specific therapeutic diet. So I wouldn't be able to say how compliant a kid can be to, like, a therapeutic ketogenic diet. I can't say.
Yeah, gotcha. Okay. But for the child who is willing to bring in more protein, more fat, talking about
Yeah.
results, again, contrasting what you learned with conventional training, are the results just far better if somebody is willing to, at least for the most part, introduce more protein, whole foods, a little bit of fat, some animal products, any of that kind of thing?
I would think so. I can't run a controlled trial on it. And perhaps I'm over-indexed on this stuff, right? I always have to say that's my bias, but I would think so. There's a doc. He used to be the medical director for one of the major treatment centers. His name is James Greenblatt, and his book on anorexia, and he has a couple blogs on this. He considers a vegetarian style diet to be one of the major risk factors for eating disorders in kids, just because you can't get what you need. So in my experience, if you can have more animal-based foods, you're just going to feel a lot better.
Gotcha. That seems very consistent with, again, some of the authors that you mentioned, their work, all the case studies that are starting to pile up with this stuff is really interesting. I love the way you present your work, again, not just with the children, and you are obviously working with kids, adolescents, young adults, that kind of thing, but you're also working with parents. How does that kind of therapy work?
Yeah. One of the great things, and there are limits to what we know. Uh, one of my favorite things to talk about is Cindy Bulick at UNC Chapel Hill did a major genetics study on anorexia, right? Tons and tons of genomes. And what she found is that if you have anorexia, you are metabolically compromised. You can see it in the genes. What we don't know, are you metabolically compromised because you had anorexia? Or do you have anorexia because you're metabolically compromised genetically? We can't see that. But I think as we get more and more information about the biology and about the mechanisms, it can take some pressure off the parents. We don't live in this therapeutic world where it's like the parent's fault that your child has anorexia. That is gone, that's done, that's over. It's also not what I experience. Like, I work with awesome families. I really do. I have yet to meet a bad family who I've worked with. Like, by and large, I find people love their kids. They want to love their kids. They want their kids to be well. And the more we can empower parents with information about what is happening in the body, we don't really know the physiology. We don't know the mechanism by which anorexia occurs yet. We have theories, but it's not been conclusively proven. But the more you can equip parents with this information, the more you can just take some weight off of like a family unit. And is it that dad works too much and we separate? Those things are relevant, right? Those things are relevant for the peace and the harmony of the family day over day, but they're not causing a profound restrictive eating disorder. And that, I find, has been so empowering for parents, just to say, like, I think you're doing awesome. What tweaks can we make? You know, you're not at fault. I'm not here to indict you.
Interesting. So you're not seeing like shaming issues. Like I
Yeah.
remember as a kid where like my parents bought me husky clothes and they made it a point to tell me like these are husky clothes. Like are you like not seeing that anymore?
Um, I wonder if we've moved away from that. You see size bias, like, but what I find with parents is like I just believe parents want what's best for their kids. Like I just think parents know what's up, and I want to equip parents. I remind parents all the time, like, you know how to feed your child. You don't need me to feed your child. You fed your child for 13 years, you know, and so if there is size bias, right? Like if parents are like concerned about, because I work with kids on both ends of the spectrum. If parents are concerned about their child's weight, I usually try to remind myself, like, they want their kid's life to be easy, right? They want their kid to be happy. And then we can do some work on the parents on like managing their own anxiety. In my experience, that's typically what it is. Like the parents need to do some work. What were your parents concerned about that they were like talking about the husky clothing, right? Like, whoa, they had a function to that. They were trying to get some need met there. And if you can help the parents to sort of like resolve some of their own anxiousness, then the kid will feel a little less shamed.
Yeah, gotcha. Okay, that's fascinating. Okay, so also had this question for the parent who dealt with their own kind of health issues. Maybe they were overweight, they had mental health issues themselves. They have kids that are kind of in that age range, maybe they're 12, 14, whatever. The parents find a low carbohydrate, ketogenic, possibly carnivore diet. They change their diet and notice all these certain benefits. How in the world do you contrast the difference between the parents knowing that like animal products are the best and we don't want to feed our kids Oreos, but we also don't want our kids to fear Oreos? That seems like such an impossible juxtaposition to like be eating a certain way, notice all the benefits, but then how do you like what is a normal quote unquote diet for a child for parents that are in that situation? You know what I mean? Like that's
Yeah.
tough.
Yeah, Casey, like I could have a podcast just about this topic, like you know, I spend an inordinate amount of time thinking about this stuff. How do you raise kids? What do you keep in the house? Like, one of my favorite people to hear talk about this is, oh, sugar, Healthy Rebellion. Help me out.
Healthy rebellion.
Uh,
Shoot, I should know.
uh, Rob Wolf. Rob Wolf
Yes.
and Rob and Nikki Wolf have two daughters, and I part of why I listen to their podcast is actually just to catch them talk about parenting things. But I think what he and I don't have children myself, so there's my disclaimer. But I think and I think they have a great model of doing it. And as a therapist, this is what I would recommend. You run I just really believe in parent autonomy. So you stock your house with what you believe to be optimal foods. There may be foods your kids can have that you don't have for yourself, right? Like that, right? There may be some different kinds of things. that you feel like metabolically or otherwise your kids can handle. Some cassava tortilla, right? Whatever it is. But I think if you're in a dialogue about it with your kids, like about just these are foods that we feel best on. And we don't have to be afraid, and just really having a continued conversation about it like you would anything else in your house, like any other norms you would like to establish. Why do we keep a tidy house rather than a haywire house? Why do we attend church rather than don't? Why do we not attend church rather than we do, right? Whatever it is. And as you can sort of just be in an ongoing conversation with your kid and know that your goal is to launch them, right? In the same way as I want to inspire confidence in the parents I work with, your job is to inspire confidence in your child so that they can be launched. If you say no, 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 no all the time to your 10-year-old, that's not inspiring a lot of confidence in him. And so, yeah, just how much can you be in a dialogue about it and create safety where your kid goes out and eats tons of things on a weekend away with his buddy's family and comes back and has like migraines or whatever he struggles with. Is there that norm of we talk about this in this house. We talk about it and it's safe and it's not shaming that he can come back and be like, oh, I ate tons. Like we stayed up all night one night and had XYZ and I've been feeling bad for 2 days, right? Like, is it safe for your kid to talk through some of that with you and just keep trial and error like all of us?
Yeah, I love that. That's very empowering for the child. And I think what I've noticed with a lot of people out there is like your kids are smarter than most of us assume, and they can handle this kind of thing. And so I love having that open dialogue. Yeah, Katherine, if you don't mind, tell us how you're working with people these days. Where do you do your most work? Do people need to see you in person? How are you helping people these days?
I do some coaching for anybody who just like has what I would consider to be like subclinical food stuff. So if you have an eating disorder, I have to see you in the state of Connecticut. I am licensed in the state of Connecticut. If you have clinical levels of OCD or anxiety, I have to see you in the state of Connecticut. I can see you telehealth or in person. But if you have sort of just like some food stuff you'd like to negotiate, you would like to be more compliant with a certain dietary pattern, or you'd like to see if you can have benefit from a therapeutic ketogenic diet, I do some coaching on that nationally. And that's what I do. In my practice in Connecticut, I see teens and young adults and their family, and it usually looks like some spectrum of anxiety and body image stuff in my private practice. And then when I'm with Backcountry, I see clinical levels of eating disorder.
Gotcha. Well, this is amazing. I would say that anybody who reaches out, or I'm sorry, when Nicole reaches out to recommend anybody, they require zero vetting. I would email them immediately, regardless, because she's amazing. And whoever she says we need to host, we need to host. I was lucky enough to be able to vet you anyway and listen to your podcast appearance on the Low Carb MD podcast with Tro and Brian, which was absolutely amazing. I know you're very, very busy and you've taken time out of your workday to be on our show today. We really, really appreciate you and your work and all your time in this very enlightening interview. Where would you like people to go to find you and connect with you and your work?
Find me at wellsupportedbehavioral.com. I'm Katherine Tague on most social media. I'm not so active, but I'm trying to be better. I'm trying to be more active.
I don't like it either, the social media stuff, but it's where people are. And so you kind of have to. So I get it. But yeah, thank you so very much for all of your work. I think it's amazing. You have such an amazing story. And I think you're going to help a lot of people out there. And certainly this was a great conversation. I'm very excited to get this out. So thank you very much, Katherine, for all of your work. And thank you for taking time out of your very, very busy day to be with us today. We really appreciate you.
Thank you, Casey. Thank you so much.
It was such an honor. And this has been another episode of Boundless Body Radio.